everyone, this is Courtney Spitzer, the project coordinator for our Early Psychosis Learning Collaborative. Please feel free to introduce yourself in the chat box. Now I just want to review a few housekeeping items before we begin. Next slide, please. Participant microphones have been muted at entry and you'll be able to unmute them during the discussion portion. During the presentation, if you have any technical difficulties, please use the chat box. This webinar is being recorded and will be available for viewing at a later time on the MHTTC website. To reach us after the webinar, you can email newengland@mhttcnetwork.org. Next slide, please. This slide provides a description of our disclaimers for MHTTC. Next slide, please. The MHTTC network uses affirming, respectful, and recovery-oriented language in all activities. That language is strengths-based and hopeful, inclusive and accepting of our diverse cultures, genders, perspectives, and experiences, healing-centered, trauma-responsive, inviting to individuals participating in their own journeys, person-first and free of labels, non-judgmental and avoiding assumptions, respectful, clear, and understandable, consistent with our actions, policies, and products. With that, it is my pleasure to hand it over to Dr. Raquel Meshullam-Gately for introductions.
Thanks so much, Courtney, and good afternoon, everyone, and thanks so much for joining us today. My name is Raquel Meshullam-Gately. I am a psychologist from Beth Israel Deaconess Medical Center in Boston and the co-director of the Beth Israel Deaconess site for the New England Mental Health Technology Transfer Center, or the MHTTC. So I'd like to welcome you to today's webinar, which is part of an important series of initiatives through the New England MHTTC to disseminate knowledge of evidence-based practices for working with people with psychosis and other serious mental illnesses. So to that end, I am delighted to welcome Drs. Schnitzer, Evins, and Cather to address tobacco cessation in adults with serious mental illness. I'll provide very brief introductions because if I described all of their accomplishments, that would certainly take much more than the length of the presentation today. So first, Dr. Eden Evins is the founding director of the Massachusetts General Hospital Center for Addiction Medicine and the Cox Family Professor of Psychiatry at Harvard Medical School. She studies the effects of drugs such as nicotine and cannabinoids on cognitive, behavioral, and brain measures such as impulsivity, risk-taking, reactivity to drug-related cues and relapse to drug use, psychiatric symptoms, cognitive function, addictive behaviors, and brain function. Dr. Evins has conducted large clinical and implementation studies, including a series of studies that have changed clinical practice guidelines for tobacco cessation treatment. Her work has been featured in media outlets throughout the world, and she has over 23 years of continuous funding from the NIH and authored over 150 publications. Dr. Corey Cather is the director of the Mass General Health Center of Excellence for Psychosocial and Systemic Research, the director of psychological services at the MGH Schizophrenia Program, and an associate professor of psychology at Harvard Medical School. She has extensive experience as a clinician researcher with first episode or early psychosis, as well as with chronic schizophrenia, and she has developed an international reputation as one of the few practitioners in the US skilled in cognitive behavioral therapy in schizophrenia. She has participated in a number of trials that investigate the efficacy of combined behavioral and psychopharmacologic treatments for nicotine dependence in smokers with severe mental illness, and has manualized treatments for enhancing motivation to quit smoking, smoking cessation, and relapse prevention for this population of smokers. And finally, Dr. Kristina Schnitzer is a graduate of the Mass General Hospital McLean Adult Psychiatry Residency Program and is a clinician researcher working as an attending psychiatrist at the Freedom Trail Clinic in Boston. She currently has a K-12 research grant focused on tobacco cessation for individuals with serious mental illness, and will graduate with her Master's of Public Health from the Harvard Chan School this spring. Her research interests focus on improving health-related outcomes for individuals with serious mental illness. So, without further ado, it is my delight to now turn things over to Doctors Evins, Cather, and Schnitzer. I am very much looking forward to learning from them. Dr. Evins?
Fantastic. Thank you, Raquel and Courtney. Thank you for the opportunity to be on this platform and amazingly, like reaching people from coast to coast. It's fantastic to see you all signing in. We've got neighbors right around the corner and people as far away as California. So thank you so much for joining us. I'll get right into it. Today, we're going to talk to you about tobacco use in people with serious mental illness. I see a number of people, that's your specialty, who are joining us today, so that's fantastic. Please interrupt us as you go along with questions. We'd love to have this be a conversation. And Courtney, I'm going to ask you to notify me when there's a question, if that's okay. I'll try to keep an eye on the chat, but there's so many people are introducing themselves, that'd be hard. I want to talk to you today about the trial that we did to try to improve treatment for tobacco use disorder for people with serious mental illness. Next slide. People with serious mental illness smoke. They smoke with the highest prevalence of any other group we know, aside from potentially those with addictive disorders. And the key is that most people who smoke want to quit, but in study after study, if they only get a behavioral intervention, and I say only, I mean these are fantastic behavioral interventions that work for many people. Only about 4% of people with serious mental illness are able to successfully quit smoking. And so we've done study after study, like about 7, to show that pharmacologic treatments work and are well tolerated in people with serious mental illness, with quit rates, in the 20 to 40% range, which is pretty respectable compared to those without a psychiatric illness. They're well tolerated, as we showed pretty definitively in the Eagles trial, which led to changes in the FDA regulations. The box warnings were removed both in the United States through the FDA and in Europe through the European Medicines Association. But these meds are underprescribed. So they work, they're well tolerated, and they're underprescribed. And as a result, people with serious mental illness are really being undertreated for their tobacco use disorder, and they're paying the price with a mortality disparity that's as big as a generation, right? 25 to 30 years. So next slide. So we set out with my fantastic colleagues, Cather and Kristina Schnitzer, who came along as a resident during this trial, a trial where we tested basically systems level interventions to see, could we get abstinence rates up, and could we do that largely through increased provision of evidence-based care, which really meant first-line pharmacotherapy, varenicline or dual NRT or their combination. So what we're going to talk about today is we tested the effects of 2 years of education to primary care providers, where we went out and really showed them the database on safety and efficacy of smoking cessation treatment and the impact of no treatment, right? With and without a community health worker support. And the idea of the community health worker was both to support the patient primarily, but also to support the prescriber, such that if they prescribed the medication, they could be sure that CHW was going to get back to them with any adverse events, with any problems with getting the medication, et cetera. And the CHW also, when they had the permission from their patient partner, would work to improve communication between patients and the primary care doctor. And our main outcome was abstinence rates at 2 years, but a specified sort of secondary outcome was use of first-line medication for tobacco use disorders. And importantly, we went on to enroll almost 1,200 people, and the only criteria for enrollment was that they had a serious mental illness that made them eligible for psychiatric rehabilitation services. So they were quite functionally impacted by their psychiatric illness, and they smoked tobacco regularly. And they would agree to talk to us for 5 minutes once a year for 3 years. That was it. They didn't need to want to quit smoking. So next slide. And so what we mainly want to talk about today is some of the questions we had for the community health workers, right? So when clinicians know the importance of providing effective tobacco use disorder treatment, so if they've gotten provider education on the background, can the CHWs essentially provide health education to raise the priority of smoking cessation as a goal for the patient, but also for the primary care doctor? And can they reduce the barriers to care, which are legion, from difficulties accessing primary care treatment, getting a ride to your appointment, getting prescriptions filled, paying for the copay, et cetera. Can they assist with care navigation really in this fragmented system? And can they promote treatment adherence and follow-up once this prescription has been made? So next slide. So this is a sort of a tall order, I thought, but really tailor-made for a community health worker, really working as a sort of an extender, doing things that the primary care doctors really were not going to do. So in this study, all adults with serious mental illness from the 2 large Department of Mental Health contracted psych rehab service agencies in Greater Boston who smoked tobacco regularly were eligible to come into the trial, whether or not they wanted to quit. And once we had everybody enrolled, we found out where they got their primary care. And for anybody any clinic treating at least 3 people who enrolled in our study, they were enrolled and randomized to receive provider education or not. And amongst those who got provider education, so participants whose docs were randomized to receive education, they were randomized on a individual level to receive access to a CHW or not. So we had 3 arms: provider education plus a CHW, provider education alone, and treatment as usual. And so just to give you the background of what did the CHWs do in this sort of paradigm, was they met with participants who were assigned to be offered a CHW, and they got the chance to say yes or no. They would agree to have a CHW or not, and 2/3 agreed. So again, a lot of these people didn't want to quit smoking, but 66% agreed to meet with the CHW. And if they did that, then they and their CHW decided on a schedule to meet. And mostly the meetings were in their homes or neighborhoods. The CHWs did not have offices to meet with patients. And they had a really broad mandate to basically build trust and hopefully support identification of smoking cessation as a goal. So, that old-fashioned idea of building a therapeutic alliance was really their first goal. And then to assist participants with needs that they identified, like rides to get to their doctor's appointments, not necessarily their primary care or sort of smoking cessation appointment, but to any doctor's appointment, rides to the grocery store sometimes, just basically negotiating life sometimes, despite very significant adverse social determinants of health. They were educated as tobacco treatment specialists with the brief training, and so they then passed that on to participants to really educate them on the good news that there are good treatments for people with tobacco use disorder that are well tolerated and effective for people with serious mental illness, and encourage them to follow what is now best practice, which is to offer every smoker medication, not just those who say they're ready to make a quit attempt. Okay, and then to offer practical support for cessation. The average caseload was 27 participants, and they made 37 visits per month, including one-on-one visits, accompanying people to their groups or their primary care doctor visits. And they had pretty intensive supervision. And so what did we find? Well, the provider education plus CHW intervention had significantly higher abstinence rates than either of the other 2 groups. So adding a CHW to provider education significantly boosted quit rates. And those working with a CHW were nearly twice as likely to quit smoking. So actually more than twice as likely to quit smoking. It was 5% with treatment as usual, and about 12%. It was 5% versus 12% for abstinence rates. And they did that, but at least in part, by having more, being more likely to get evidence-based medications. People offered a CHW were threefold more likely to use varenicline. They got a prescription and used at least one dose. And those who got varenicline were almost twice as likely to quit smoking, right? But remarkably, just the varenicline without a CHW didn't improve abstinence rates. And that may be in a table next, but right here. So if you were offered a CHW without a CHW, so that's in the top half of this table, those you see they were, if they got varenicline, they had 6.5% abstinence rate compared to 6% with no medication. And if they had varenicline and some NRT, they had a 6.7%. So no difference. But in the bottom half, these are the abstinence rates for those who got a CHW. The abstinence rates were 5-fold higher amongst those who got varenicline or varenicline plus NRT, 4 to 5-fold higher. So to me, this was super interesting that this was this dramatic, that varenicline without a CHW really didn't budge the abstinence rates, but varenicline with a CHW really did. Next slide. Those who were able to quit, regardless of what treatment they took, met more frequently with a CHW. So again, twice as many meetings with a CHW, 23 versus 49 total over the course of the whole study, 2 years. Next, this intervention worked not only amongst those who were ready to quit, which most of our studies are in people who are ready to quit, right, across the board. That we have really almost nothing on people who with serious mental illness who are not yet ready to quit. But, in those who were not ready to quit, the abstinence rate was 7.6% in those, and compared to those who were ready to do something, which was 18%. But to get sort of, nearly an 8% abstinence rate amongst people who weren't even thinking about trying to quit smoking, to me is really hopeful that if we do implement the practice guidelines as they're currently written, which means offering treatment to all smokers, we can make a significant dent in this this behavior that costs significant years of healthy life and of life, period. So, this was a 2-year program, and in that time, almost half of those who weren't ready to quit at baseline actually made a quit attempt. So imagine if this got built into ongoing care, right? This 45% who've made one quit attempt, you imagine over time will be more likely to actually make a successful quit attempt, so that over time, and it may take a while, we could even increase the abstinence rates even further beyond the 7.6% that we saw for pre-contemplators or contemplators coming into this study. And the CHWs in this trial emphasize building longitudinal relationships with clients, spending time building rapport with those not ready to initiate a quit attempt. And so to me, and I'd love your input from folks who are here with us today, my hope is that this kind of a role is just sort of tailor-made for building into the clinic structure, the psychiatric support structure in our care structure today. So do we want to, were there any questions now? I could pause, but otherwise it's Corey Cather will talk about the provider education that we offered. This is, so we focused on smoked tobacco. Some people were using electronic cigarettes also. It was pretty low though, something like 2% were using electronic cigarettes. They're more expensive. I think might be an issue.
Yeah, and something else we see a lot with people who are using electronic cigarettes with serious mental illness is we see a lot of difficulties kind of keeping it up. There's a lot of charging and thought and planning that needs to go into using at least the new generation electronic cigarettes. And what we wind up seeing is a fair amount in practice. We see a lot of dual use. I'd be very interested to hear what other people see. So we see people who are vaping sometimes and then also using smoked tobacco. So, even though, there's some thought that moving towards electronic cigarettes for people might be a good thing, that's true as long as they don't pick up smoking tobacco as well. But we do see a lot of that in practice. All right, well, it's my pleasure to tell you a little bit about what did we educate these providers about. And, of course, this education is happening at multiple levels, right? So this is the information we're presenting in talks to the primary care offices, often during their sort of team meetings, serving lunch and that sort of thing. But we're also using this as the educational base that goes to the CHWs as part of it. And then it's also filtering to the clients. So there was a lot of thought that went into what we wanted to educate providers about. And there was also a lot of thought into what kind of title should we use. So one thing we did was we said, this is good news for patients who smoke. We wanted to present an optimistic message that, we knew really at the beginning of this study that there were safe and effective treatments available, but that they were being underutilized. So to frame it as something, as an opportunity. And we also thought, many of these providers, because of our fragmented care system, weren't only going to be working with people with serious mental illness, but we're also going to be working with general population smokers. And we wanted them to pay attention to the message and be broad. So we talked about it as something prescribers can do to help patients with and without serious mental illness to stop smoking. Because to some extent, the recommendations are actually pretty much the same. As Eden mentioned, you want to treat all smokers and offer all smokers medication treatment because that produces the best results. So, we already talked a bit about the elevated rates. I mean, just to get a sense of how elevated the rates are among smokers with serious mental illness, they're quite high. So people with schizophrenia, 64% are smoking tobacco, 44% of individuals with bipolar disorder versus, something like maybe 13 to 14% of the general population now smoking. And we already talked about the enormous, excess mortality, largely related to cardiovascular disease that is driven by smoking, by tobacco smoking. And this is really unacceptable and has been the case for a very long time. When you look actually at rates of smoking among individuals with schizophrenia today, for example, approximate rates of smoking in the general population in 1950. So we really have not made a dent in this population in terms of accessing treatments. And that's something we also be very interested in hearing from you all about, what you perceive as the barriers and how they accord with the barriers that we think are in place. So, it's a huge opportunity to save lives. People can quit smoking. Among those who quit, even among general population smokers, there is relapse, but we have some studies that suggest with maintenance treatment, we can actually get very good long-term quit rates and maintenance of quit among those who have quit. But it's important to think about every quit attempt as moving people towards abstinence. This is a chronic condition. It needs to be treated like a chronic condition. It takes smokers on average something like 5 to 7 times to try to quit. So every time that people quit, they learn something, they're in a different place. And the idea of remaining engaged with people over a long period, as we were in this study, we think is a pretty important care model. So at least 2 years of engagement perhaps might be what it takes. Next slide, please. So just to kind of tell you, the data that we basically base this on, I mentioned that we already sort of knew that there were safe and effective treatments available, and we knew they weren't getting out there. And the best evidence to date is probably from the Eagles trial. So this was an extremely large trial that had a non-psychiatric cohort of about 4,000 people, and then a psychiatric cohort that was a little bit less. And you see it here broken up to the first group of bars is the non-psychiatric cohort, the second is the psychotic disorders cohort, and the third group is the mood disorders cohort. Everyone in this study received a medication together with brief behavioral counseling to quit smoking over a period of 12 weeks. And you see just by visual inspection, right, of these graphs, you see the same pattern is happening in these three populations. And so you probably are wondering, well, what's the blue bar? Because the blue bar looks like it's doing the best. Well, that is treatment with varenicline. And what we saw was that treatment with varenicline was superior to treatment with bupropion or NRT, the green bar and the purple bar respectively, and that they beat placebo, which is the gray bar. Now, just to point a couple of things out, so when you look at the psychotic disorders group in the middle here, you see what we've been talking about with what is the placebo quit rate. It's under 5%, right? So 4. And this has been replicated in other studies as well. This really emphasizes what Eden was saying before, that having people quit without a medication is not going to yield a high rate of cessation in this population. You also see that bupropion and NRT, and in this case, Eden mentioned earlier dual form NRT, which is probably better than single form NRT in this population. It certainly is in the general population, but in this study, it was single form NRT. It was the patch, and again, this was all blinded. The clients didn't know what they were getting. The assessors didn't know what people were getting. Okay, next slide, please. Thanks. So basically, these treatments work, and this is to look at safety. So again, you see the same pattern is pretty much there for all three populations. And you do see that the non-psychiatric cohort, the first collection of bars here, the rates of adverse events, and these are neuropsychiatric serious adverse events, thought things like suicidality, agitation, et cetera, that were deemed to be at least moderate severity, that they are lower in the non-psychiatric cohort, but they're not significantly different across the 4 treatments. They are higher in the psychiatric cohorts, the psychotic disorders and the mood disorders cohorts, so ranging from about 5 to 6.8%. But again, they're not significantly different by treatment, and perhaps reflect some of the kind of natural course of illness and perturbations that we see in psychiatric illness. So this study actually led to the removal of the black box warnings on bupropion and varenicline. And clearly showed, along with a lot of other literature, this is not the only study, but it happened to be the biggest head-to-head comparison, that these treatments are safe and effective in psychiatric populations. Next slide, please. So the other thing, we presented to people, and this was based on focus groups that we actually did at the outset of the study. We didn't sort of just think these were myths. We actually heard these as myths when we talked with providers. The idea that people with serious mental illness don't want to quit smoking. Sometimes I call this also sort of the other fish to fry argument. Like, this is not the most important thing to people. And that's absolutely counter to what we hear when you actually talk with patients, that the majority of people do want to quit and think this is important. The idea that quitting worsens psychiatric symptoms, in fact, in the general population, and we still really need a meta-analysis to see if this is actually true in psychiatric populations, but in the general population, long-term, you see reductions in anxiety and depressive symptoms with quitting that are actually commensurate with what you would see with antidepressant treatment. So it actually is a pretty good antidepressant and perhaps anti-anxiety. And it's hard for people to grasp this, because what they perceive is that cigarettes are taking care of anxiety and depression, because in the moment they're taking care of withdrawal. So it's really important to present this information to people and actually provide this optimistic outlook that they may actually feel better. And there's certainly, as you saw from the Eagles trial, there's no evidence of exacerbation of symptoms that's different by treatment. The medications are incredibly important. We really hope we made that point. That is probably one of the most essential points that we made to the providers, the CHWs, and to the clients who participated in this. The other thing that's really important is this idea, that you don't prescribe medications only to people who say right at that moment that they're ready to quit. That medications may actually help people become more ready and confident in their ability to quit. And we can talk a little bit more if people are interested about how that might work. But I'd like to show in the next slide some other strategies for quitting. So there are, at least 3 ways to quit smoking. So, general population smokers may kind of show up at their provider and say they want to quit smoking. They might get prescribed a medication, and they might do something like a fixed quit where they quit a week later. We actually recommend separating the quit date from the initiation of the, because in our experience, what that does is it separates out the experience of withdrawal potentially from medication side effects. So we actually do something more like a flexible quit, typically, where we start the medication at least 4 weeks ahead of a person's quit date. The other type of quit is a gradual quit, where people start taking the medication and reduce slowly. So they kind of reduce by 50% maybe over the first 4 weeks, an additional 50 over the next 4, and then they continue reducing with the goal of quitting by 12 weeks. And we recommend continuing maintenance medication for after that. So just to be clear, a general population smoker might get 24 weeks of medication. Actually, in our work, we have shown that maintenance medication for those who actually quit all the way out to a year improves maintenance of quit. So we actually have extended and believe in maintenance treatment for smokers who successfully quit. But the idea is you have to hang in there with people and not just pull the medication just because they're not quitting within the first 6 months, for example. I'm going to turn it over to Dr. Schnitzer, who's going to talk a little bit about what we've learned about from your responses from a survey, as well as what we're thinking about in next steps with CHWs.
Thanks so much, Corey. And thanks to all of you who took the time to fill out the survey ahead of this listening session. So after we did this trial and in thinking about everything we know, we're wondering, can we take what we've learned through the provider education, through our experience with the CHW role, can we expand the CHW role to other mental health providers? And can there be potentially a role specifically for psychiatric rehabilitation specialists in promoting tobacco cessation? See. So to briefly go over the survey, and please, please feel free to unmute yourselves and to jump in, particularly if something that you responded it is highlighted here. We really would love to hear from you and think about and brainstorm together what is the best way for us to think about changing the system and getting this care to more patients. So looking organizationally, whether or not your current organizations provide tobacco treatment was mixed, whether this was emphasized and prioritized at the organizations where you are. But the vast majority of you agreed or strongly agreed that tobacco treatment should be a part of the mission of their organization. And we're happy to help think with you of how we can do better in that regard. Some of the client-related questions. So some of you had concerns that quitting tobacco could make psychiatric symptoms worse. As Dr. Cather mentioned, that's a common thing that providers and patients and other care members think, but actually the evidence shows that psychiatric symptoms tend to get better. And so that's something that I have to repeatedly tell patients and other providers who I work with. Many of you had concerns that if clients are using other drugs, quitting smoking at the same time would be too much. And along those lines, that tobacco is maybe less harmful than other drugs that they could be using. And we see and hear this a lot. And I think there's this discrepancy between, very acute complications from other drugs that patients could be using as opposed to more of the chronic long-term effects of smoking tobacco that we see. And, that, as Dr. Cather mentioned, are so largely contributory to this mortality disparity. Many of you expressed the concern that smoking helps clients cope with the stress in their lives. And this is something actually that the CHWs in our study targeted explicitly. So working with them, what other things can we do, that are healthier aside from picking up a cigarette when we're stressed? And the CHW specifically worked to increase their clients' day structure so that it wasn't just revolving around smoking, both for socially and stress relief purposes. And then just to review a few of the personal responses. So the vast majority of you want tobacco treatment to be a part of your work, and you're concerned, moderately to extremely worried about the health consequences of smoking for your clients. Many of you do feel confident in helping your clients already, which is wonderful. And we were really thrilled to see, almost across the board, everyone is strongly interested in learning more, tools, techniques, resources for how we can better help our patients. And then just a final note from the survey, we included, an item on burnout, and it's common. We're seeing it not just in this survey, a small survey that we did here, but nationally. And one thing we've thought about is, can we leverage kind of the success, the potential successes from treating tobacco to help combat that a little bit. If you can be confident that your efforts are moving the dial and extending the lives of your patients, can that help counteract some of the burnout that's really common? We have a few questions here just to prompt discussion, but again, really happy if anyone wants to jump in. Some ideas for things we were hoping to talk about, how important is helping your clients with their physical health, quality of life? Is this currently part of your professional role? Do you wish that it was more a part of your role? How would you like tobacco cessation to be prioritized? What do you think is feasible given the other demands of the jobs in which you work? And, along the lines of burnout that we referenced, how might experiencing making a substantial positive impact on your client's physical health affect your job satisfaction? So maybe I'll stop here. We have a few more discussion questions on the next slide, but we can see if anybody has thoughts on these or any other aspects of the presentation so far. And Corey and Eden, please feel free to jump in as well.
I'm just giving people time. I was just going to respond. Someone put in about working with younger smokers, younger individuals, and seeing high rates of vaping. And that certainly mirrors what we're seeing in the general population too, right? We're seeing extremely high rates of vaping, exclusive vaping, at least to start, among younger individuals. We are working on some protocols to help younger vapers.
That's not what we see by and large for those with serious mental illness. And this program was absolutely focused on tobacco smoking. And many different forms of tobacco smoking. So there's cigarettes, there's many cigars, there's roll your own. But we really want to reduce cardiovascular disease and illness, which tobacco smoking really accelerates. So
Yeah.
I'm really curious to hear, to understand from the audience, from those of you who are community health workers, how the role that we gave to CHWs fits with the CHW role that you are implementing in your job, or that if you aren't a CHW but you have CHWs in your agency, how they are able to work. Our CHWs gave people rides, etc. I would love to have feedback, because we're being charged now to try to basically implement this intervention more broadly, which is super exciting. And how realistic is what we've done? How real world is it? How real world is the caseload?
I'd like to share. My name's Kim. I work at Greater Nashua Mental Health Center in Nashua, New Hampshire. I'm actually a research interviewer for a health-focused program called ProHealth, and we are branched off of our integrated care clinic. And part of our motto, you could say, is really focusing on integrated healthcare, because, and I just wanted to answer that first question on the slide, because we really believe that mind, body are kind of interconnected, and when one's not doing well, the other's not going to do well either. And part of my program, actually, we have a smoking cessation program. And I really wanted to get some info from this training, because from what I've seen in our very small population, a very few amount of them want to participate. And it's interesting because we give like a financial incentive if they successfully prove that they've been able to remain smoke-free for a period of time, although ours is much smaller than some of the studies that you guys talked about. But yeah, we do have CHWs, but they're mostly in like more clinical roles. And I don't know if there's a big focus on the tobacco use, because that's what they refer them to my program for. So it's quite interesting, because I think the caseload that we are working with here, it's a little different from the numbers you guys are showing. Like, not as many people are even ready to quit or even talk about it. We pay them to come in and even explore their ambivalence. And that's been a huge struggle for us to even use the motivational interviewing to get them to agree to talk about it.
Right. I wonder what would happen if your focus was on a trial of cessation treatment as opposed to focusing on abstinence. Like, you know, are they willing even to take a medicine for a month that would improve their ability to quit, right? It would reduce their craving between cigarettes. It would reduce the reward they would get from each cigarette and help sort of start, you know, that extinction process that we learned about in school, right? I think that was key. That and the CHWs really helping people to understand that there's a good chance that they could succeed if they tried with the right treatment.
Yeah, this information is very helpful. Thank you, guys.
The other thing we didn't mention is that we do have some peers who had quit smoking who tend to kind of share their story of quitting smoking with the group, which I think did help people feel like it was possible, as to see someone that was like them that had done this, and to see someone who was really long-term quit and had reaped a lot of benefits over the course of their life. So I think that also helps. I think there's a lot of worry about being coerced into something too. So I think that, you know, people need to experience that the person who's working with them is truly open-minded. And of course, there's a dilemma with, you know, contingency reinforcement. It's nice to have reinforcement, to have that to end, but you ultimately need the person to internally feel some reinforcement or to identify what the internal reinforcers are to keep it all going.
Yeah. I think that's one of the things the CHWs did was to help them to experience enthusiasm and belief that they could succeed and like allow the patient to borrow their confidence, if you will, for a bit and be willing to try. And I think helping them understand that there was a decent chance they could succeed, you know, lower that barrier, that risk, that fear of failure barrier for folks, so they would try the treatment and come to the groups, which I think was really key to the success rate in this program.
Yeah, I think rapport is one of the more important things in helping people change their minds about it. I noticed that because we also have we're able to detect the amount of carbon monoxide in their system using certain devices for our program. And a lot of them might produce a number that's a lot higher than what they reported how many cigarettes they smoke per day. And I think there's a lot of shame that comes from that. And it's funny because, you know, working in this clinical role, it's like there's a certain level of self-disclosure too, because how can you build rapport with them on this topic without needing to admit that you smoke or whatever, you know, just to build that rapport with them. So yeah, I'm learning a lot. I appreciate all the feedback.
Thanks so much for sharing what you're working on. The other thing to think about with high COs is cheaper products. So mini cigars, they're cheaper and they produce higher COs, even when people are reporting smoking, you know, less of them.
I see Robert mentioned in the chat, I don't know if you want to say any more about this, Robert, but that your agency was awarded a CCBHC grant from SAMHSA and working on increasing screening rates and assigning a care coordinator. I think we'd be interested to hear kind of what the role of that care coordinator is going to be. And we're hoping to work with CCBHCs as well to try and scale up this project. So would be really interested to hear about yours. Sure.
So I will preface it. I'm not attached to the CCBHC, so I only know what I've been told about it. But we are in the first year. It's a certified community behavioral health clinic grant. We do have some priority populations that we're looking at, specifically pregnant women, veterans, individuals at risk of either removal from their home or hospitalization or incarceration. And they are implementing through our access center increased screening for individuals that meet that priority population. tobacco screening is one of them, as well as alcohol. They're also looking at overall health outcomes. They actually do waist circumferences, weight, those sort of things. Are they connected to a PCP? And then the role of that care coordinator, we have rather lengthy waiting lists. I'm in a rural community, and that care coordinator continues to work with the individual, typically over the phone, while they're waiting to access services, so they can talk to them about quit links and different services that are available in the state of Maine to individuals. We also do smoking cessation. We have 4 clubhouses, the international clubhouse models, and within our clubhouses that serves people with serious mental illness, they offer smoking cessation on site.
And how much integration is there with prescribing smoking cessation pharmacotherapy, or is it typically behavioral groups alone?
I believe it's typically behavioral groups. Many of our individuals may be also attending our medication clinics, but I do not know if the psychiatrists are actually prescribing medications for tobacco use disorder, or if they're referring them to their primary cares. I just don't know the answer to it.
Thank you for describing. I think you also mentioned something so important, which is actually documenting in the electronic mental health record what's going on with smoking. So that's like a starting point for a lot of places, is to just know who the smokers are and to be monitoring it over time.
Other thoughts? Anyone else here have experience? Or does this seem feasible, this type of role, particularly as Eden was mentioning for folks who are CHWs currently?
I'll jump in there with a more specific question. So community health workers in our organization, there are a few who do work in maternal child health, in a few, but they are specifically not allowed to give rides to their patients. And I was sort of curious about that, because I feel like a big part of what our CHWs did was to provide transportation to folks with serious mental illness who struggle with that. So I'd love in the chat, or to email me separately, or if you're willing to just speak up. Okay, so here's somebody saying they're not allowed to provide transportation. Kathy, where is your organization?
Hi, everybody. I'm in Columbus, Ohio, Franklin County Public Health. And we either have to, the transportation thing is really difficult because we can't provide it. And then even if they have transportation barriers, of course, like with their Medicaid program, they can usually get medical transportation, but not transportation to other, like if we're trying to get them to another, resource in the community or whatnot.
Yeah.
But there are many times where it's very frustrating personally, because people do want that, if you could just pick me up and take me here or take me there, or like I was thinking about that discussion about how important is it helping your clients with their physical health, quality of life. Well, with a couple of clients, they can't work due to their mental illness, and they are not allowed to work because of the severity of the illness or whatnot, is what I'm still learning about this. But and then I'm kind of wondering, well, it has been on my mind, well, what are they doing all day? And how easy is it going to be for them to quit smoking? Because I'm still learning, of course, about a couple of their newer clients, but what are they doing each day? And they're young. They're like, a couple of them are in 20s or 30s. And so that's a concern of mine, is just, I don't know if you guys can talk about any of that today, but what do you advise? Like if they are not allowed to work, because of the danger to themselves or other people, but they're living in the main part social life with everyone else. I don't know what to advise for that, but anyway, but yeah, the transportation thing is definitely a challenge.
Yeah, so many good observations. I mean, I think you're right that smoking can kind of fill a vacuum when there's no meaning. And of course, that's one of the things that we want to do for people is we want to help them find meaning and a valued life that they want to live. And I think that replacing that function of cigarettes is a key thing. Sometimes people don't work, or you get the message that they can't work, or they think they can't work because they are worried about losing entitlements. And usually that's good to check out with actually a supported employment specialist, because oftentimes it's not actually true. You can work some. And the dangerousest thing, I don't know about that, but you always try to find workarounds, right? What kind of work? Can people do remote work? Can people do some sort of, job where that's not an issue? Creativity is like 9/10 of a lot of our work with people.
Yeah. Or if one person who couldn't work with other people, but got a job, in an animal shelter, they're just different. Just the creativity, I think, is important. Kathy, would you be allowed to say get an Uber with a person, or is there that flexibility?
No, we're not allowed to ride in a vehicle with them at all, just for safety purposes is what we've been told. So we can meet them. So if somebody wants us to meet them at the doctor's appointment or something like that, of course we can do that.
So you could call them an Uber and meet them there. Yeah.
I can call them an Uber. I can't pay for the Uber though. So most of our clients are low income. So we have all the other urgent needs of eviction, housing, all of that stuff. But if they live on the bus line, we can provide bus passes, which is helpful. But yeah, we can't call an Uber either unless they can afford to do that. But yeah.
Sure.
Yeah.
That's helpful.
How interested would people be in getting more in-depth training about how to work on tobacco cessation specifically with clients as a CHW, or people who feel like they would like that? There are things they don't know. Also you have to think about your own smoking yourself, right? If you're a smoker, it may be difficult to work with people who are smoking or trying to stop smoking. I wonder if people in CHW or psych rehab roles have felt like their employers have given them good access to smoking cessation resources for themselves.
I'll speak up real quick about that. Our employer does a good job with us as employees. I'm not a smoker, but I do feel that almost every single client that I have worked with, not every client, of course, but a large majority, whether they have severe mental illness or some type of mental illness, stress, anxiety, depression, a lot of people do smoke, and it is definitely a concern where I feel like I do want more support and understanding about, because sometimes people say, oh, well, I've already tried the patch. I already tried the gum. I've already done this. I've already done that. And, a lot of things like that, where then I'm kind of feeling stuck. Sometimes the insurance helps and they give the counseling and things like that. But as a person talking to them, and that trusted person where we're talking, 2, 3, 4 times a month together, it would be nice to have some more information about how to help them with tobacco cessation. And again, I am a very creative thinker and all of that, but again, I'm also smart enough to know I don't know everything. So any help is going to be great, to be able to try to help them.
It's wonderful openness. You're right. I mean, you don't know the data, right? You have to know some data in order to know how to respond to those questions. Even varenicline, there are studies that show that 45% of people who tried varenicline before and failed varenicline weren't able to quit, were able to quit with a subsequent trial. So there are good data suggesting that re-challenge is actually important. But you do have to know that stuff, and you have to be able to, have some weight behind your encouraging words.
Right. So we provided the CHWs with all the education and then some that we provided to the primary care doctors. And often they came in and helped basically reinforce what we taught the primary care doctors, which was fantastic. Took some.
Yeah, I would like to add that it's a big challenge, to have them, stop smoking. Even that, provided like a 20 feet area from the house to go to get, their smoke. But the problem is that, the staff, many of them, complain about that because of secondhand smoking. And they are afraid, for their health, for their own health. And because, not all the clients, all the persons, use that 25 feet area to smoke. They stay, next to the house. And this is also, liability, sometimes, some of them, take the liberty, to even smoke in the home. And we have to constantly, going after them and knock at the door or check on them because, some of them, disregard, the rules and everything. You know what I mean? So this is a big liability, on our program, on our staff, on everybody, who frequent, the house. And the secondhand smoking is a very, very big challenge also because, we have staff that complain, not only complaining about it, actually go, think that, they have some illness resulting of secondhand smoking. So, yes, this is a very good, big initiative, to have them, if they can, stop, smoking. But I don't know what else, we can do because, more than 80% of our clients, always smoking. If you find one or two, who never been smoking, in their life, even like, serious illness, but they still smoke. And some other clients, introduce newcomers to the smoke also. Yes, even that they never smoke, but just, by contact, talking to them, they accept, this client, for their friends, they feel like, the necessity to follow whatever, they do.
Yeah, it's a very
we have examples like that.
yeah, very prominent culture.
Yes. Yeah, this is what I have to say, about that. So.
Fantastic. Moisty, are you in Brockton? Is that where you're based?
I'm in Brockton, Massachusetts.
I think we've met. Thank you for joining us. Yeah.
Yeah, it could be. Yes. Yes.
Well, thank you very much. I don't know if Raquel or Courtney want to say anything in closing. I appreciate your generous thoughts and your time. Thank you so much.
Well, I first wanted to thank the three of you for this wonderfully informative, helpful, and engaging presentation. It is such a valuable intervention that you're all providing. And I'm wondering how people can find out more about getting additional training from you, because from what you presented, I think it really underscores the importance of therapeutic alliance and the work that community health workers and other mental health professionals do that adds value above and beyond any medication. So I'm really, again, curious about how people can find out more about this training.
Well, so Raquel, we should talk offline about where we want to post the training materials. We'd be delighted to work with you. I think we're going to work with the MGH Psychiatry Academy to also sort of post the training that was done, basically, at least so people can see what it was. But we'd be delighted to work with you to find platforms that makes it easy for people to find that information.
That sounds wonderful. Thank you so very much.
Thanks, everyone.
Thank you.
Yeah.
Thanks very much.
Courtney, I'm sorry, Courtney, you had a few just final housekeeping remarks.
Yeah, so thank you all so much for such a wonderful and informative presentation. And thank you all for joining us today. You'll be receiving a survey link to a short evaluation survey afterwards, so please be sure to fill that out.
That would help us a lot, actually. We'd love to see how you answer the survey after coming to this talk.
Yes, great. And again, thank you so much for such a wonderful presentation.
Thanks
Bye,
again.
everybody. Thank you.